All right. Everyone, thank you so much. We're about to get started. Thank you for your patience. All right, see, just another bonus for being in the room because you get the right view if you're in the room. So yeah, sorry everyone online. All right, so welcome. I'm Stacey Farr. I'm gonna go ahead and get started. So welcome to the IQ Forum for January. No, that's not working. So let's try this. Okay, advance with this. There we go. So I just want to start and thank kind of our IQ partners. We have a number of partners who contribute to our success. So thank you all for being a part of High IQ. And just kind of reminding everyone who's not familiar with the Institute, you know, we do have our vision of Kansas City delivering the highest value, most equitable healthcare in the nation. And our mission is also to catalyze and facilitate multi-stakeholder collaborations to improve the quality, value, and equity of healthcare in the Kansas City region. And I want to give one of our big activities that we have going on in the Institute is called Tiara, which is a training program in implementation science and quality improvement. It's cutely named Training and Implementation Actionable Research Approaches, which is why it's called Tiara. But really what this program is it's really kind of the basic science of how to really change healthcare and be a change agent. And so what we do is use a lot of quality improvement methods married with implementation science, which is a really rapidly growing need and demand for people to learn and know. And so we have this training program. It's going live January 29th, as long as I get everything completed. And this is just the QR code if you know any providers, payers, any hospital leadership, anyone who's on the front lines, anyone who's in research or does quality improvement, who wants to really hone their skills and learn kind of the science of how to marry implementation science and quality improvement. This is a really great training that we're offering. There's two different options: live meaning it's every other week during the spring semester, January 29th to May 1st. Otherwise, we're also offering this as completely self-paced as well, so people can take it as they go. So it's open for registration. There's a QR code, share in your networks, and here for any questions, you know how to reach me via email if you have any, or Pat. And then you are all here today for the IQ Forum, as you all know. And then this is kind of our lineup for 2024. I know there will be probably a few additions. We're currently working as a group to, as you all know, we work on regional quality improvement projects that are pretty large and involve a number of different stakeholders in the community. And we do want to give updates on those projects as well. So there may be a couple supplemental sessions that we're going to fit in. We're just working on the logistics of when that will be, probably later this summer. But otherwise, these are the forums that are on the schedule. So mark your calendars and register. And then today, while we are all here and very excited, this is a really exciting topic. So today we're talking about emerging trends in the big business of healthcare. You can all read this, but I guess I could too. Despite accounting for the U.S. economy, healthcare is traditionally a local activity with sole practitioners serving independent hospitals supported by local insurance companies. But over the past few decades, however, there's been market consolidation of hospitals into large national health systems, with hospitals, payers, and even private equity purchasing physician practices. Even insurers and drug companies are consolidating. And this forum here today is going to talk about different perspectives on these trends, the impact, as well as concerns of the evolving trends in the structure of U.S. healthcare. So before I turn it over to all the amazing speakers, I just wanted to give like really high level context. I thought was kind of interesting, just pulling, very quick Google search last night, about 10:30 p.m. But, if you're looking even this is like venture capital, right? So this firm, General Catalyst, just 2 days ago announced that they're going to launch a new company and acquiring, Akron, Ohio's Summa Health. And then we have, health insurers in the business where we have, Elevance Health, which is, the corporate name of Anthem, is acquiring Paragon Healthcare this year. And then Cigna, whose talks just crumbled with, Humana, is now in talks with Healthcare Service Corp to sell its Medicare Advantage business. And then we also have the health systems that are merging, and these are big health systems where we have, Jefferson Health and Lehigh Valley just signed a letter of intent within the past a month. And then, as we all know, very locally here, we just had BJC and St. Luke's Health System close on the first of the year on a $10 billion merger. And so, those last ones particularly are some of these examples of these cross-market mergers where it's really what these are is kind of two different buckets, right? Where they're having either two different health systems that operate in completely different geographic markets that come together. And so that's kind of, what we see with BJC and St. Luke's, for example. And then we also have health systems that are acquiring independent hospitals in markets that they do not operate in. And I just kind of wanted to highlight, so this is from Kaiser, and this is just an example of combining health systems and these cross-market mergers from 2021 on that are just, that are 5 billion plus so it's like rapidly growing. These are huge health systems, and what in the world's going on? We'll hear this from our speakers. And what I, think many of us are most worried or interested about is some of these trends in terms of, we're also focused on, right, forever, the triple aim, which then became, the quadruple aim, which is now the quintuple aim. But really what we're trying to do is how do we improve quality in care in the US, because we're starting to really, really fail at that, and at the same time contain costs. And I think some of the big concerns, are not something to be minimized. For example, 2020, and MedPAC came out with a report and said there's a preponderance of evidence that suggests that these hospital consolidations lead to higher prices. And I'm speaking there about the horizontal sort of consolidation, where these hospitals are like what I just showed in the cross-market mergers, compared to also even the same thing happening in vertical, where like hospitals are buying up physician practices. We see that there's a 14% increase in same service for the same service when there is physician hospital integration that exists. And I know there's people in the room that also have written recent papers on some of these things, so it can also speak to this after. So we see costs are going up. Okay, well, what's quality doing? It better be going up demonstrably, right? So I don't have slides on that, and I'm hoping all of our other speakers do, but I just kind of wanted to set the stage that these are big, big issues, and this is impacting, the whole nation. And I cannot wait to hear what everyone else has to say about this. So that being said, I would love to take this time now to turn it over to our first speaker, who's Scott Christensen who'll be providing us with a healthcare advisor perspective on partnership drivers and emerging trends. And that's my last, there we go. So thank you. And get tea and cookies.
Okay.
Scott, are you
Good
there?
afternoon, everyone.
Okay,
Can you hear me okay?
Yes. Can you share your screen?
Yes, I am. Can you see it?
No. Oh dear. Scott?
Yep, I'm sharing screen on my end, and I can see it in the Zoom.
Are you there? There we
I
go.
am, yes. Can you hear me?
Yes, thank you.
Okay.
Thank you
Well,
for
good
being
afternoon, everyone. Absolutely. Good afternoon, everyone. I'm Scott Christensen. I'm a senior vice president with Kaufman Hall. We are a advisor to a lot of the nation's leading healthcare systems, and I spend a fair amount of my time working on partnership in the healthcare space across both the provider and the payer side. So really excited to share some of what we're seeing in the marketplace with you all today. Our first speaker intro gave a lot of prelude to some of the things that you hear me talk about today, but I'm going to cover why healthcare organizations are partnering, and then also a view of what's to come next. So first and foremost, I think in terms of why healthcare providers are partnering, if you look all the way to the right on this chart and you see the relative performance of hospitals and health systems, particularly from a growth and then a margin perspective relative to all of the other players in the healthcare industry, you see a lot less growth and typically a lot lower margin performance. And so that's driving organizations to consider how they gain access to incremental growth and population to serve, and that oftentimes leads to a partnership-oriented conversation. So that's the first thing. The healthcare market is continuing to consolidate across all different sectors, and that's continuing to drive health systems and providers and payers to the table to work together. The next thing to consider is just the shift of care outside of the four walls of hospitals and physicians in particular. So it's kind of a cool graphic here. If you start in the middle, where you see typical hospital care in the emergency department, ICU, labor and delivery, et cetera, and then look at each of the concentric rings that emanate from that. So medical, surgical, ambulatory, diagnostics, et cetera, you see that less and less of that care is remaining within health systems. And so that's another key factor. It's driving folks to partner in ways and with organizations that they may have historically viewed as competitors. But now, given the new dynamic and especially the desire to shift care out of the hospital in a lot of markets, you're seeing these folks partner up together. Payers vertically integrating and controlling more of our healthcare delivery is another key thing. Obviously, Optum is sort of the largest and most prominent example of this. You can see over the last decade, the total share of earnings, the source of margin that Optum generates for and United generates for its shareholders is coming more and more from direct provision of healthcare services, and they expect that to continue. I think a really shocking statistic here too, when you think about the size of this, is $108 billion of intercompany eliminations between Optum and United. So that means they're taking in premium on the United side and then paying the healthcare provider side on Optum. So $10 billion healthcare organizations is the size of Optum's provider footprint, which is obviously really staggering. So all that to say, what's coming next? And we see a few different trends, one of which was already hit on. So the continuation of a lot of cross-market M&A activity, deepening of payer and provider relationships and shifting focus towards value-based care, and then investing in provider enablement and other elements of the care continuum are three of the big trends that we see and that I spend a lot of time in the day-to-day working on these as well. So as you already well know, in your local market there, BJC and St. Luke's have come together, Intermountain and SCL in Colorado, Utah, and Montana, and then obviously Advocate and Atrium coming together in Wisconsin, Illinois, and North Carolina. So these deals are going to continue. I would say of all of the deals that I'm actively working on right now, they are all cross-market in some way. So, if you were to compare that to a few years ago, it was comparatively much fewer. So a really significant portion of the M&A activity that's going on and will continue to go on for the next several years, we anticipate is going to be of the cross-market variety. And then from a payer provider perspective, coming out of the pandemic, if you look all the way over to the right-hand side of this page, we see that both providers and payers are viewing partnership differently. Providers principally looking for financial viability and a meaningful size to the value-based care business that they do today. If you look at the total revenue, for example, that a typical provider produces, very little of it is actually on the basis of quote unquote value-based care. There's certainly some incentive programs out there, but the total size and impact of those programs is still relatively small for most providers around the country. So they're looking to change that, and they're looking for partners that are willing to work with them to do that. And then from a payer perspective, it's still an incredibly competitive marketplace, especially in the commercial and Medicare Advantage lines of business. So they're looking for sources of membership growth to improve the member and the consumer experience, and then also really think about price, and the premiums that they're charging, especially employers. Inflation has obviously wreaked havoc on a lot of small and medium-sized businesses around the country. And so payers are looking for relationships with providers that allow them to compete in the marketplace as well. The other thing from a value-based care perspective is you start to see cross-market opportunities in that realm as well. So Kaiser and Geisinger are coming together to form Risant. is one example of how health systems are looking for opportunities to really invest in value-based care and recognize the benefits of it in multiple markets. And last thing here, just as I mentioned around, investment and provider enablement, AI and all of its associated potential benefits are some areas that we're starting to see more and more interest in, especially from providers that are still trying to wrestle with things like labor cost and the ability to supplement their workforce. And then as you look across the continuum of care, a lot of focus right now on moving into the home, whether that's through home infusion, for example, figuring out what the future of the hospital at home program looks like over the long term. And then on the primary and specialty care side, a lot of interest in single specialty models. The private equity groups have been really, really active on the far right-hand side here, especially in orthopedics and oncology, and they are becoming more active in cardiology as an example. So there's a lot of kind of niche investments that are being made, and also just a ton of activity that's occurring from a physician practice perspective when it comes to private equity investment. I'm sure we'll hear more about that today. So those are some of the big things that we're working on, and also where we expect to see a lot of activity going forward in the marketplace. So I know we'll have some time to take questions at the end, and I'm certainly happy to do so. Thanks again for having me today.
Scott, thank you. Not the X, not that one. Come on. Dick Flanagan.
Does the mouse work? If I click.
It does. Tech was going to come in and try to fix the notes issue, but they're not back yet. There you go.
See how far the mouse works.
Everyone, Dick Flanagan is about to.
Hi, guys.
For those who are online.
Well,
We should probably put it in presenter mode though, so he can.
yeah, present mode, see if that'll do it. I don't know if it'll work or not. Okay, great. Hey, I'm Dick Flanagan. I have to make one, I'm going to talk about private equity and investors. I actually do work with private equity firms, and I'm an investor, and I'm an operator. I'm a not-for-profit guy, and so I think I kind of bring a lot of different perspectives. I've grown up in the technology business. I spent 28 years most recently at Cerner. Over the last year and a half or so, I'm CEO of a not-for-profit called Digital Health KC, which seeks to grow the HIT infrastructure and business around the KC region. So I'm going to try to give you a balanced perspective on the investor side. You'll decide at the end through questions whether it was balanced or not, but I think it's important to get that out there. And the first two presenters I think have covered. I have this kind of thing called fast facts. If you would advance the slide back, it's a clicker doesn't want to do it. I think you've seen all most of this, but a couple things that have not been mentioned so far. We are still with a hangover from COVID. And to put simply, in the Kaufman Hall, by the way, if you ever want to track statistics on the health of hospitals and others, Kaufman Hall is the standard. These are wonderful folks, and I refer my go-to, for some of their public information. So I really think Scott, has much better looking slides and really some great information. But what's not been mentioned is, in addition to that workforce is still a huge problem. And anybody running health systems today, it's stabilized in air quotes. Raises are starting to normalize, but we've come to a very difficult time. And that is impacting how health systems and investors are thinking. And we have not solved. We've talked a lot about quality, we've talked about that cost, but we haven't really talked about access. And some of these changes that are taking place are having a significant impact on access. That's something. And access is very closely tied with affordability. And I think we're seeing some trends that really exacerbate for most of our citizenry their access and affordability of healthcare. And you've already heard, so next slide on. So the other thing that's not noted yet 46% of physician practices are now working in health systems, and over 90,000 physicians work for United. So 90,000 physicians are employed by United Healthcare and its subsidiaries. That is dramatic. And that's why you can see that $108 billion intercompany transfer for United from the payer side to the provider side. So those are big, big numbers. You've seen some of these numbers before. The really important piece that I think is that hospital and physicians are only 50% of the market, and yet that's mostly what we talk about. So we talk about national health expenditures. It actually came down as a percent of total GDP. That's not happened for a while. It came down not because healthcare got more efficient or cheaper. It's just that inflation drove up the rest of the economy at a faster rate than healthcare for a change. So the thing that we'll talk a little bit about briefly in terms of investment is drugs. People complain all the time about drug costs. They have been below 10% of national health expenditures forever. So while they're a problem, there are more price decreases in total than there are increases this January so far. So we're not going to talk a lot about the drug problem in healthcare, but it's a big part of where investors are pouring a lot of money in there. And so it's not a big topic today, but something we should be around. Next. Okay, so bigger getting bigger. I think we've already covered this. I think it's important to know that the consolidation.
Curiosity, what's the other 40%? So 10% of drugs, 50% are administrators.
It's home health, it's long-term care, it's nursing services, and there's
And healthcare IT, of course.
of course. And that's generally mapped into the other costs, by the way. And there's just a big other. There's just all kinds of other things that happen. Emergency care, air transport. Others about 25%. And it's broken down into much, much smaller categories. So we've already talked about some of the consolidations. I think it's important that you have to study healthcare by market, which is price maker and price taker. A price maker is, I'm a dominant insurance company, I get to pick the price. Price taker is a hospital, a single hospital in a metropolitan market that doesn't get to set price. It doesn't have any services. And the opposite happens on the payer side, where you have a large number of payers, and you have a dominant provider. Provider becomes the price maker, and the insurance companies become the price taker. So it's important that healthcare gets studied, really. That's where all healthcare is located. Next. Okay, so value-based care. I love the couple of fast facts there. 10,000 people a day are entering Medicare. More than 50% of people are choosing Medicare Advantage, and 3/4 of the Medicaid plans are already in a managed care type plan. And Medicaid is much bigger than Medicare. Now, the problem with Medicare Advantage, if you're a provider, it's the worst of both worlds. You get Medicare reimbursements, and you get all the payment challenges of commercial insurance. So you've heard about the president announced yesterday, I think it was, or today, about trying to come up with standards for prior authorization. And that's because hospitals are having to invest more and more time to get paid on stuff that they get paid actually less and less per unit of service. So these are some really big challenges that everybody's facing. And the commercial world is still dominated by fee for service. It's been between 17 and 20%. The big health systems always report, oh yeah, we're doing value-based care. What you're having is quality gated payment, not value-based care. And I think it's noted by Scott Call. Today's topic is not data and analytics or AI, but we are seeing AI aggressively move into the provider sector, both in terms of documentation for providers, but more importantly, the administrative roles are increasingly going to be driven by use of AI and by process technology. So we'll see some changes there. Okay. Now, why are they fix it? If this market is so challenging, why are investors pouring $1 trillion over the last 10 years into buying these kinds of companies? So next slide. Investor owned is not a new phenomenon, and it is not evil, right? And by the way, most of healthcare is owned by investors, including physician practices. They're just themselves the investor owner. And for all of the complaining about these terrible private equity companies, you know who's selling them? We are. We're selling ourselves into investors. So as much as we think it's evil that certain people have bought them, the not-for-profit systems agreed to sell themselves. Summa just agreed to be sold to general capitalists, right? Physicians are agreeing to sell themselves over the decades to the investors. So we are the investors. So we're not evil people that are doing this. There's a whole, and The best run health system in America is probably HCA. And does so with high quality, and they're not perfect, right? So I know some people, we have a lot of HCA, here in this market, but certainly very well run health systems. Decision ownership's been part of healthcare for decades, so this is not a new factor. Now we're going to talk in just a moment about what the regulatory response has been. Private equities put $1 trillion in. There have been 8,000 transactions over that period. This is a massive shift in who owns healthcare. But overwhelmingly, they're not buying physicians and they're not buying hospitals. What private equity ventures investing is everything else that happens in healthcare, the other that we talked about listed up there. But they're investing heavily in technology, in AI, in infrastructure, and that's where you see a lot of private equity money, in addition to what you see in providers and hospitals next. So, is it good or bad for healthcare? I would like to say there are some benefits to what you're seeing from the investors. So, first off, they're the ones that are taking the risk. This is also what includes VC in new technologies for healthcare, new drug development, new devices, next generation treatments, next generation diagnostics. So that is not coming from hospital-based organizations investing. And for all the discussion around how much money the NIH puts into this stuff at early stage investment, which is a lot, by the way, and it's great. There is far more money being invested in healthcare infrastructure and technology by the private sector through VC and PE and others. And as I mentioned, they're unlocking the value for a lot of these practice owners. People are willingly selling to these investors. They do hope to drive efficiencies, and that's where some of the downside comes in with concerns. And if you talk to people that complain about, whether healthcare has become too greedy, honestly, they're not just talking about investor-owned. They're talking about the not-for-profit health systems as well, who increasingly behave like investor-owned systems. And that's not a knock. It's just they've got margin pressure, they've got growth pressure, and they're having to make some of the same kind of decisions. What are the concerns? There have been, it just was noted, there are real concerns over quality in some of these transitions. There's definite concerns over whether cost goes up in consolidation. That's been documented, talked about in the previous couple of folks. And I'm concerned personally because when this happens, as costs go up, access goes down. And I think access is one of the great crises that we're still facing here in American healthcare, in spite of having the Affordable Care Act and insurance marketplace and the like. And a lot of these organizations, particularly outside of hospital-based practice, don't have the requirement to serve the community benefit. They don't fill out that community report every couple of years. They don't report to anybody on community benefit other than their investors, and they do tend to have shorter investment life. So, final thought is next week's is what's the regulatory response? People aren't sitting back going, well, that's been interesting. What they've done, the state's attorneys general have actually put the brakes on any more consolidation within the metro, which is why I call it mentioned. The big trend is it's cross market, right? So we're leaving the market where there are no longer FTC concerns. And that's where state attorneys generals may come into play. Surprise billing, which was allowed people like you see Envision, Team Health, and the air ambulance companies to take advantage of people when they have ED visits and others. That has been shut down for the most part. And in fact, Envision declared bankruptcy, right? And Team Health is under pressure. And air ambulance companies have gone out of business because they can no longer take advantage of you're not in network, even though you show up in network ED. We've got now price transparency legislation. It's not going particularly well. We really can't figure out what stuff is paid for, but it's a darn good start. And we as consumers have complete access to our digital record. Again, not happening fully, but these are all foundational elements to change the way we create more transparency across. So those are my thoughts. I think the investor community actually has done some good work. And in reality, there's also some real concerns that I think we'll be talking about. So, thank you.
Thank you, Dick. Everyone online, that was Dick Flanagan, CEO of Digital Health KC, right? I said that right.
You did. Thanks.
And next, we will hear from Erica Anderson with Kaiser Permanente. I hope. There we go. Yeah. Here we are.
Okay, all right, thank you, Pat. Okay, so today, I want to thank everyone for their time today. I think Scott pretty much covered off on the mergers. So today I'm really going to talk about culture and community and the importance of culture. As we have seen all of the mergers that have taken place, and Stacy, you also covered off on a lot of the mergers as well. This past year, we did see 55 mergers in 2023. As we think about all of the reorgs that have happened in the past year, and we think about employee satisfaction, we think about all of our associates, and we think about the workforce, and we think about what all of our employees have gone through, and we think about quality, and we think about who we are actually serving at the local level, and we really think about what that means to our patients, and we think about what that means to our community-based organizations. And we actually think about what that means to our policymakers and those that are actually making the decisions for us. And then we actually think about what that means to ourselves as those of us that actually work in healthcare, and then actually to our family members, right? To those of us that we actually live with, that experience those same conditions that we're actually going through. What does that mean to all of us? Reorgs affect everybody. Culture affects everybody. Healthcare is local. When we think about all of the mergers that have happened and the reasons behind these mergers, and they've been discussed, majority of them, the reasons are to increase population size, it's to negotiate higher reimbursement rates, it's to streamline operations, and then it's to address policy, and then reimbursement charges. We know that CMS has rolled out a lot of changes this past year, moving into 24 and moving into 25, a lot of the reimbursement rates are going to change. It's going to affect a lot of hospital systems. We know that this past year, a lot of employees and a lot of health systems were laid off. It's because they are preparing for the bonus years. They're preparing for a lot of the changes in their reimbursement structures. Our nurses are going through a lot of changes right now. We move to the next slide. When we really think about what our nurses and our workforce is actually going through, when we think about as leaders, how we're leading everybody through these changes, the culture that we are actually instilling in those that we serve, it matters. It truly matters. So as leaders, it's so important that we practice empathy. It's so important that we listen to each other, that we open the door and we actually sit down and we talk to each other. It's so important that we are curious, that we're curious about what's happening at the local level, that we listen to our CBOs, that we listen to our for-profit organizations, that we listen to payers, we listen to our policymakers, that we sit down and we really co-create these solutions together, that we practice and we engage in collaboration, that we really practice. We practice consent. And I heard you, John, the other day when you said 2 days ago, like you said that you had been in meetings and you had a pilot and you had heard that you had capacity building. And then you came back a year later and you didn't have the funds that you needed to continue your pilot. You thought you had consent and you didn't have consent. So I think we should really practice and continue to practice building trust with each other, but that really takes consent. And when we do have consent, ensuring that that consent is something that we continue to build and that we ensure that we don't break that consent. Next slide, please. Culture really matters locally with everyone that we build trust with, and ensuring that those strategies are co-created, that we really align all of our deliverables, that when we collaborate and we develop a model together, that we really explore all of those alignments. So we have so many different community-based organizations in the Kansas City market and across the region that have so many fantastic strategies and roadmaps. But we're not aligning them. We're not really taking a look at all the community health improvement plans and really taking a look at those deliverables and working together concertedly. We're not taking a look at all of the funding streams that are coming into the Kansas City market and the region and really aligning them. And I realize that takes like a fantastic CRM, right? That we're all like plugged into and feeding information into. So that's going to take time. We need advocacy for localized care. We really need to take a look at how we can really, at a local and a regional level, come together and consent to really developing a plan where we have coordinated care, where we have set up a system where our nurses feel like they are, that they have all the tools and resources that they need. And that for that next generation of leaders for the workforce, that they feel like they have the tools that they need. And when we think about that next generation of leaders, Stacy, it's amazing that we have Tiara, but what are we doing for our youth? I think it was Tony about a month ago that was talking about the youth. We've got to have a plan for our youth. We've got to figure out something to actually get them into the healthcare system. Why? I think about this all the time at Western Civ. Like, why are our students taking Western Civ if they want to go into a nursing degree or they want to become a physician? History is important, but why are we not teaching them the history of nursing, the history of physicians, the history of CMS, the history of coding, right? Do they really need to know Western Civ if that's the particular direction they want to go in? They have a lot of that history in high school. But when they're going into college, they really need some of that foundation that is really baked into a liberal arts education. So if we could really figure out the way to really develop a pipeline for our students to go into the healthcare industry, and we could get them in there sooner, we could actually have a robust healthcare system for that next generation of leaders. We need to really measure and create sharing agreements for our CBOs. We've talked about bidirectional loop. We've talked about creating an opportunity for our CBOs to be reimbursed. We need to move in that direction. Our CBOs need to be reimbursed for the referrals. Our physicians are being reimbursed. We need parity for the reimbursement structure. I know many in this room want to work in that direction. And so hopefully we'll get to that point. We'll be able to create a system where we will actually be able to collaborate. And we'll create a model where we can actually align our funding streams and we can figure out a way where we can actually have sharing agreements where we can share data. And we can align all of the payers. I know it seems like a daunting task, but we can do it. I think we can get all the payers together in a room and get them to align on something, get them to consent and hold their feet to the fire.
From your lips to God's ears, I say.
I think it can be done. We had a community conversation. We had them all in the room.
Yeah. But we didn't get, the follow through, right? We didn't get the action, we didn't get the commitment, and we don't have a working operative plan to help, bring them started.
Well, let's.
This is good. We're gonna have a great discussion. Very
Yeah,
excited.
I agree.
So thank you very
You're
much.
very welcome.
Thank you. Again, everyone online, that was Erica Anderson with Kaiser Permanente. Thank you, Erica. And I want to remind everyone online to drop your questions in the chat and we'll get to them in the end. And next, we will hear from Barbara Zabawa, Associate Professor of Law with UMKC. Barbara, bear with me. Presentation mode, and I'll stay close to you too, so I
Okay.
can move your slides for you.
Thank you, everyone. I'm so thrilled to be here. Thank you to John and Patricia and Stacy for allowing me to speak to you guys. I am new to the Kansas City area. new to UMKC law, where I teach classes in health and wellness law. So my perspective is coming from a lawyer who's practiced health law for over 20 years, still has an active practice, and they represent a lot of physicians, some insurers. And so I see some of the stuff that's going on that I'm going to talk about on next slide, which is an argument to relook at the corporate practice of medicine doctrine, and I'll explain what that is, to control some of the private equity investment in physician practices in particular. That will be my focus. Dick already gave some great information on private equity investment generally. So I'll just kind of scan through these points, but investment in healthcare by private equity firms has grown exponentially from less than 5 billion in 2000 to now over 100 billion. And in 2021 alone, there was 733 deals amounting to $77.5 billion in investing in healthcare. And physician practice acquisitions in particular have experienced a 6-fold increase since over the last decade, from 39 in 2010 to 221 2019, which totals over 1,200 out over that decade. And the most popular types of physician practices that are being acquired are oncology, gastroenterology, OBGYN. Cardiology is also now getting popular, radiology, primary care, dermatology. In fact, I think I go to see a dermatologist on Monday that I'm pretty sure is owned by a private equity firm. Next slide, please. And because this is a real, well, private equity, as Dick pointed out, I mean, there's been investing in healthcare for a long, long time, physicians, yes, and managed care, and but private equity is relatively new, and so there aren't a ton of studies, but I reviewed a lot of different journal articles recently where they've sort of summarized the different impacts private equity investment has had on healthcare delivery thus far. And in the hospital sphere, the studies that have been conducted show increased charges, more privately insured patients as opposed to public insurance, decreased staffing ratios in the nursing home sector, which I think has the most experience with private equity investment. There's evidence has shown increased mortality of patients due to reduced staffing levels, a decline in quality measures, and higher rates of hospitalization, emergency room visits, and higher Medicare costs. Now, for physician practices, the few studies that have been conducted on the impact of private equity investment have shown higher prices, increased testing and hospital admissions and utilization, more aggressive billing practices, and use of more mid-levels. And according to the Stanford Law Review article that I reviewed, their conclusion was, after their survey of all the studies that have been done, that no study has found significant improvements to healthcare quality, efficiency, costs, or access as a result of private equity acquisition, at least especially in terms of physician practice. Next slide. So this might be elementary. So I will just briefly say that, you know, the mechanism that private equity uses, at least this is how it's being done with my clients that are being bought out, is they're cutting staff, they're replacing higher paid staff with lower paid and arguably lower quality staff. They reduce facility hours, they close less profitable facilities, and they pressure physicians and other workers to perform more profitable procedures. And these actions arguably lead to poor quality care, less access to, or at least less equitable care. So next slide. And this impact on quality of care by private equity investments in physician practices is on top of a pre-existing dissatisfaction by patients with the healthcare system. Now, this this is where I really want to kind of what I really want to highlight. That I just finished a law review article that's being published in the American Journal of Law of Medicine. And I talk a lot about the wellness industry and how the wellness industry stands ready to fill in gaps that the healthcare industry has created with regard to patient dissatisfaction in the lack of focus by medical care in preventive care and wellness. Consumer surveys have shown that patients want more time with their providers and more emphasis on prevention and wellness. And the healthcare system, generally speaking, is not delivering on that front. And so a lot of patients are turning to other sources to get that, to fill those needs. And the wellness industry is one of the areas that they turn to get that attention, to get that emphasis on preventive care and wellness. And that's driven by the fact that studies have shown physicians on average spend 11 seconds with their patients before they interrupt them. And that is driven by, of course, the environment in which they work. I'm not blaming physicians. These studies are just kind of pointing out that the business of healthcare has resulted in lack of attention to what the patients really need, what the patients really want. Yes, it might be great for cost cutting, which is important because the whole reason why the corporate practice of medicine was created was because of outrageous costs. So you can turn to the next slide. So the corporate practice of medicine, what is it? It is a legal doctrine that's been around since the 19th century. It was created by physicians, basically. The American Medical Association was instrumental in creating this ethical code that then was translated into various legal formats, sometimes statutes, sometimes case law, and sometimes attorney general opinions. And it was created based on these three primary policy concerns. The fear by the medical professionals that allowing corporations to control physicians would result in the commercialization of the practice of medicine. 2, that corporation obligation to shareholders may not align with physicians' obligations to patients. And 3, employment of physicians by corporations may interfere with the physician's independent medical judgment. So there's a premise here that the practice of medicine is a fiduciary duty to patient care. And that if you have unlicensed individuals or entities, unlicensed meaning not licensed to practice medicine, controlling and directing how medical care is delivered, that will impact that fiduciary duty, that trust, that the medical community, at least in the 19th century, believed was critical to delivering medicine to patients. And so states, state by state, started adopting corporate practice of medicine laws. So this chart shows the different states and where they stand currently on the corporate practice of medicine. And I will just highlight that Missouri is in a no corporate practice of medicine column. So the state of Missouri does not recognize the corporate practice of medicine, meaning that it's totally fine in the state of Missouri for corporations to control and direct physicians. Other states, like Kansas, for example, do recognize the corporate practice of medicine, but they have exceptions. And I would say that's probably most states. They recognize the corporate practice of medicine to a degree. They often carve out exceptions for hospitals, for managed care organizations. Sometimes they delineate between for-profit hospitals and not-for-profit hospitals. So non-for-profit hospitals can employ and direct and control physicians, but for-profits can't. So this chart just sort of summarizes where the different states fall in their adoption of the corporate practice of medicine. But overall, over the last, especially since managed care, the Managed Care Act, the 70s, the HMO Act, I should say, came into being, corporate practice of medicine has really fallen out of favor in the state enforcement scenes. There haven't really been a lot of recent case law using the corporate practice of medicine. Some states still are very vigilant. California and New York being the two that come to mind, sometimes Texas. But most states just don't prioritize the corporate practice of medicine anymore because it got in the way of cost containment measures. The healthcare industry or federal government, especially when Medicare became prominent payer in the healthcare system, costs were getting out of control and third parties needed to enter into the fray to try to bring those costs down, and corporate practice of medicine was a barrier to that. And so it just sort of fell out of favor, and it's kind of just become obsolete in legal circles. A lot of lawyers just don't even really consider it anymore as something to worry about. Again, depending on your state, but overarching theme is it's not really that big of a deal anymore. I'm arguing, next slide, that, and this is just reviewing Missouri and Kansas, so you can stick over that every time I explained it. So I'm arguing that reviving the corporate practice of medicine, at least the principles behind it, maybe not the law itself, but the principles behind it, that foundational message behind it, which is the physician-patient relationship is a fiduciary one. It's one that physicians need to have in order to meet the needs of their patients, which isn't happening right now, at least in the aspect of patients wanting more preventive care, more wellness care, and physicians' hands being tied because they have other stakeholders who are telling them how to practice. That if we can bring that back, that the principles of the corporate practice of medicine, maybe through standards on private equity firms that want to invest in healthcare. I read someone suggested a federal act that would basically create similar standards for healthcare investing, as a special category of investing because of the social contract of healthcare, meaning there's this undercurrent of wanting to provide safe, effective, and equitable care to everyone. And right now, the pendulum has swung too far to the profiteering motive of healthcare, that if we can resurrect the corporate practice of medicine or its principles, that maybe we could find some balance in trying to meet the needs of patients, which are not being met, and still trying to contain costs. Thank you very much.
Thank you, Barbara. Thank you. So, everyone, that was Barbara Zabawa, Associate Professor of Law at UMKC Law School. I'm going to check your chats, and I want to remind everybody that you are experiencing this forum today thanks to the Health Forward Foundation. Here are some questions for us.
So I'm John Spertus. First of all, we always sort of have a coin flip in the beginning of the week about who gets to run the questions next, who gets to do the introduction. And I definitely want to do the question because I am very excited about this topic. And I could not have asked for better presentations. I mean, first, I think Scott did an amazing job, and I have a lot of questions. I hope he's still on about some of the motivations and underlying philosophy that's the thread. Ultimately, we're about how do we understand challenges of healthcare delivery and how do we sort of figure out the best strategy in our market, and a lot of Erica's concepts about culture and really thinking about how to try and leverage some of those insights into making a difference. But I love having a pro-con view on private equity and the corporatization of healthcare, and so I want to start there, and I want to for a few minutes let other people get a question in, but then go back to Scott and to Eric and sort of to really wrap up sort of where we go from here. And Dick, one of the things that, so it was a terrific presentation. I love the advocacy for private equity investment. And, I do believe that private equity is incredibly important. From my perspective, it's very different when private equity is invested in the other of healthcare. When it's invested in drug development, it's invested in new diagnostic strategies, because then the incentives seem to be aligned to create the best technology to make the biggest impact on healthcare, and then they have to sell it. And so it's got to be at a decent value. What I struggle with is when they try to get into the 50% that is healthcare delivery. And to me, there you have a very different alignment of incentives where, their incentive is to make money. As you articulated yourself, and if I go to one other VC pitch meeting where the VC guy who, is 17 years old and can't find his way out of a paper bag, but knows so much more, and basically says to me, well, look, I need a 10x return in 3 years. You hear that every single meeting, and it drives you nuts, because a lot of times you're trying to think of a longer term investment. And if you've got a 3 to 5 to 10-year investment scheme, you don't have any goals to tailor things to the community, to build sustainable infrastructure. Your goal is to maximize top line, minimize costs, show a profit, find some other sucker to buy it, and get your 10x return. And so my question to you is really, why do you think it's actually advantageous to have private equity buying derm practices? I mean, poor Barbara, having to, take over my field of cardiology, but I mean, I sort of understand the dialysis centers a little bit, because that's a little bit different, but, it does create the exact opposite incentives of societal goal for value-based care. There's no accountability for quality, and there's no desire to lower costs. And so I'd love for you to sort of focus the private equity argument in healthcare delivery.
I don't want to take sides on this. I think you make, what I was trying to say is, this is not new. It's been around for a long time. And one of the reasons corporate practice of medicine hasn't seen a lot of case laws, because a standalone physician is usually an LLC or something like that, and has a fiduciary to the patient, but also to his family and his own wealth creation, his own income. So that's always been there. And we sometimes have placed the delivery of care into this holier than thou, like, oh, we're all in it for just the patient. Hell, I've gone to for-profit, not-for-profit, and I'm telling you, they have just as aggressive billing practices. And they're, this world has homogenized because the pressures on the business model, regardless of ownership, are there.
Well, I think it's a really valuable point. I mean, and I wasn't trying to say that there are.
I really am not. I'm not defending one versus the other. I'm just saying it's been a big part. Like, I use HCA as an example because most people view them as a good actor on the healthcare stage. They're a long-term investor. But look at the markets they're in. They pick markets with good commercial insurance, growth, states that are not overly regulatory focused. You can just go around the country and look where they build and grow their hospital business. And that's why this access and affordability is, because there's all kinds of places the private equity is not investing. Investing in most rural communities, investing in, other places where we clearly still have a lot of healthcare needs. I think the question, or the point that was raised that I really do like is there something different about private equity versus investors with a shorter term horizon? I think that's a valid question that should be addressed, okay? Because I think you did a really nice job of saying, here's the playbook. And that is the playbook. Now, we all want lower healthcare costs, guys. And our employers will talk quality until they see the price of the plants. I mean, I'm an LLC and I'm out on the exchange for $2,000 a month with a $15,000 annual out of pocket and deductibles out the wazoo, or copays, excuse me. Really? This is ridiculous. So when people come in and say they're trying to cut costs, the question is, where does the cost savings go? Yep. Because insurance companies get lower rates when they have power. We know that the data's out there. where does the excess go? Does it get returned to the policyholder, i.e. the employers? Or Medicare, the largest, Medicaid, the states? Where's the extra money go when we save money?
Benefits.
That would be great. I mean.
A lot of times it goes back into the benefits, yeah.
United is an incredibly well-run company, but they figured out that when Affordable Care Act put in place essentially a cap on earnings from the insurance product, the 15% cap. So they're really smart. So they have sources of cash and uses of cash. So they built Optum. They took the cash that they were producing from the core business and they put it into the new businesses that are not rate regulated.
Exactly.
So what is every other not-for-profit doing? What is every insurance going to be doing? The same thing. And those are, that's for-profit business. So Blue Cross is I think they're public benefit corporations or not-for-profit. I'm not sure which they fall into. Yeah. They're good people, and yet some people don't like them either. So part of it is just the challenges we're having with rising costs and all kinds of strategies people are trying to come up with to save each other money. So I just don't know where.
Well, so I would just push back a little bit, and I don't need to. Other people should jump in, but it is true that there's always somebody who owns or is fiscally responsible for any aspect. And if it was the physicians or hospitals that were the investors in healthcare delivery, that doesn't bother me as much because they're generally in it for the long run, and while sure they want to maximize their income, it's a very different mindset than private equity. And we're spending a lot of time in the QBIC and HiQ really trying to think about how does our region position itself to really improve the value and equity of care in our community, right? And so, how should we be thinking about the the sort of infusion of private equity into the region? And you correctly laud HCA, which by the way has not had a 3-year time horizon. It has been in it for a long time. But I will say that locally, they've been the hardest group, and no diss on HCA, but they've been the hardest group to engage in our community efforts because they take their orders out of Nashville. To me, the biggest threat, and I love St. Luke's, this isn't a dig on St. Luke's, but the biggest threat to the St. Luke's merger is that St. Luke's, you could do everything to build an incredible case for investing in a program that improves the value and equity of healthcare. And then somebody in St. Louis has to make the final yes/no decision. Who doesn't know the market, doesn't know the people, doesn't know the CDOs, doesn't know anything about it. But they're looking at the numbers saying, well, over 10 years, this looks like a great investment, but we're short on our budget this year, so no, we'll not do it this year. As more and more private equity gets into our community, how are we going to engage with them when we have fundamentally different goals of healthcare delivery? And you don't have to answer that. Other people should weigh in, Barbara. But I don't think that. I'm not sure CPOE is going to be the solution there. We need something else, or some huge suit that scares everybody into all of a sudden caring about what medicine's really supposed to be for, right?
Yeah, well, you could bring a suit, maybe. Kansas, like I said, Missouri doesn't have corporate practice of medicine. There aren't a lot of cases, but there's still, I know the emergency medical group out of Milwaukee is trying to sue the private equity firm that controls them under the corporate practice of medicine. So that suit is pending. So there is somewhat of a revival going on. I did want to respond to something that Dick had mentioned, which is absolutely true. We can't blame private equity completely. The physicians are selling. They are selling their practices. And we have to look at, there was an article, I think it was an op-ed in the Washington Post that was critical of the criticism of private equity and saying, we have to really ask the more foundational question is why are physicians selling to begin with? And like my client that is selling to private equity, she is fed up with having to worry about administration, marketing. She wants to practice medicine. She wants to make sure she's got a secure income And she wants to leave all the business stuff to someone else to worry, have somebody else worry about it. She's in the midst of doing this deal right now. You know, so it's yet to be seen how happy she's gonna be once it's all, the dust is settled and she's now beholden to this private equity group that hopes to sell. I mean, they're very transparent about it in the deals, you know, like we want to be out in like 5 years, so we don't know what's gonna happen to you then, but you know, in 5 years, we'll hope you either go public or sell. And you know, she's been hell bent on doing it because she wants to be out. It's just too hard to practice. She worked in big healthcare, she worked for Advocate Aurora, and now she has her own practice and just wants to be a physician. That's all she wants. And so that's what's really, well, I suspect that she's not alone, and that's what other physicians want.
You know, sadly, a lot of I think that, you know, the administrative burden is crushing in healthcare today, and yet that's the natural reaction that payers have to do to rated costs because there aren't real value-based healthcare opportunities out there to align the incentives of the payers with the providers, you know, and that's a big challenge for us. And you know, I don't, you know, blame her for that at all, but you know, she'll be very disappointed down the road when she's focusing on the opportunity to focus on her patients and out of business worries, and then they start, you know, really beating up on her for not seeing more patients faster, not ordering more expensive tests from their specific imaging facility. And, you know, it's going to be a challenge. And, you know, and I still don't know how we're going to deal with that, you know, future of that. But, you know, other questions?
There's a question in the chat too.
There are actually value-based care organizations that are doing very well. And they don't necessarily turn the excess, the improved quality and benefits, but they can turn it into buying through incentives with the practices to spend more time with their patients. Because the comment about 11 seconds before an interruption says, I happen to know a little bit about this. I ran a Medicaid program in Kansas. I was the CMO at KU Health System for a long time, and I'm right now. And what I do know is that before I came aboard, I traveled around the country. I spent time in physician practices that are 25 years. Here we started up 1/1/23 in Kansas City, in the Midwest region. And so now we're through 12 states. I've seen this firsthand. I've been the one that had gone out and given checks to the physicians and their office staff so they can spend more time, they can hire a different team. Because the doctor doesn't need to see every patient trying to make it in practice. And there's a lot of help that can be done by so many other physicians. And I think that the other thing is that I think that venture capital has been given a bad rap for a lot of the failures of nonprofit institutions. Like Suma Health, we talked about, I read about it today. What happens when 40 facilities in Akron, Ohio area go off belly up? Okay, because they lost $47 million in the first 3 quarters of 2023. They lost $30 million in 2022. That's not a sustainable model. So whether venture capital can pull it out and retool it, it won't look the same, guaranteed. But I would not demonize the venture capital because, and again, I was a chief medical officer at Swedish Health System in Seattle, a much larger organization. So 26 years of being CMO, senior doc. I've seen this on the inside, and there's a lot of really poorly run nonprofit health systems, and so they'll be swept away, and it will be the corporate practice of medicine that saves her.
Well, what years were you at Swedish?
From 85 until 2007. Yeah,
I was a resident in your hospital. It was well run, actually. No, and you know, look, there are very interesting efforts to try and improve the value, and a lot of what Optum's doing is positioning, you know, I think you have to tell me fairly well for Medicare Advantage care, and Medicare Advantage is crushing a lot of providers, and you know, I think there's not an MA provider in the whole San Diego County right now because they all got out, Scripps got out, everybody got out, and it's very difficult. It's a very different mindset. It's the mindset of actually spending more time with the patients, really engaging in shared decision-making, ordering less testing, and, providers for years have been trying to, and encouraged to increase billing, and then all of a sudden, they make more money by not doing the most aggressive care, never not doing care that's needed, but much less than the discretionary care. And, a lot of the challenge in shifting physician behavior is culture, and the culture of providers and administrators, from my perspective, seems exceedingly different. How should we be thinking about trying to create a regional culture that creates not a focus, to me, when everybody, if you took me at the long-term goals, a great leader would be focusing on the long-term goals, what we're trying to achieve. Great care, great outcomes, no inequities, etc. And yet, in the different entities that formulate a healthcare system, they acknowledge that goal, but they're focused on this year's short-term goal, And so how do you create a culture that brings people to align the way they want to row the boat, even if short-term one group versus another group might not quite meet short-term objectives, but collectively they'll all do better reaching the long-term objective.
You have to really understand shared value, right? You have to understand all of their goals. So I'll take a step back to what we were just discussing around benefits, right? There's a lot of money that does go into benefits. There's a lot of money that does go into practices as well. So when we think about the money that we do pay to the practices, what if we also took a little bit of that money and we actually paid it to the CBOs? What if we walked in and we actually gave a check to a CBO because they're doing referrals? Yes, providers are also doing referrals, but what if we actually valued our CBOs? What if we also sat down, because the benefit structure, and I've been talking about this for years, I tried to get Humana to do this. What if we brought our CBOs and our community partners to the table instead of creating benefits in a silo, a payer sitting at a table and saying, I think we should do this benefit in this community because I think it's a good idea. At the corporate level, they don't know what's a good idea. Even at a market level, sitting in a room, they really don't know what's good for the community. It's our CBOs that know what's good for the community. They know where the gaps are. They know who they're serving. They know the members that they are serving. They know where the gaps are in their service areas. They're the ones that we need to bring to the table and sit down and say, what do we need? What are the benefits that we actually need? And then they're going to say, okay, this is what we have, this is what we need. And then the payer's going to say, okay, this is what we can bring you. These are gaps that we also have. And then together, they could actually develop different plans to actually serve that particular community. Then you could actually align all those sources of funding that are coming into your community and actually create a better roadmap. Yes, your benefits are 1 year, right? If you look at commercial, those can change on a regular basis because they can actually redo them. Medicaid, that's going to change as well. And when you take a look at the populations that are actually coming into Medicaid, right? So now in California, we've got undocumented that are actually going to be receiving services. Those numbers are going to grow exponentially. We're going to have so many people that are going to be receiving services. We have so many opportunities to align our benefit structures.
Well, I can see that happening in Kansas City. I didn't see that happening here.
To align benefit structures?
Well, yeah, I mean, to engage without hospitals having to buy CBOs, and how do you organize and create a sustainable infrastructure to find a more sustainable model for supporting the health of the entire community.
Start convening conversations. Yeah, just start convening conversations. Start bringing people together. Just start having meetings. Start bringing people together again, face to face, and just say we want to co-create something together, right?
We need to meet. We have a lot of talking to do. That's going to be a lot of challenge.
What we need to do.
So let me shift for one second, because I really want to bring Scott in, because I really appreciate his presentation and laying out a lot of the, I mean, you've got a vision of the whole nation and what's happening in the trends in healthcare. And, I'm trying to understand, and again, my wife will say, well, it's always about you, John. It's always about me. So it's all about me. And I want to understand the St. Luke's BJC merger, right? So here are two hospitals, and the same thing can be for Kaiser and Geisinger, you know, you have two hospitals or two health systems in completely different regions. You know, St. Luke's and BJC already had combined purchasing organizations, so they weren't getting better, they're not gonna get a better dollar return on buying catheters and X-ray machines and all that. And they're not gonna have more leverage. I mean, maybe they'll have more leverage with United, maybe, you know, but they're not gonna have more leverage. I mean, you know, the number one commercial insurer in Kansas City is BKC, right? United, if you know, may insure both St. Louis and Kansas City, but you know, there's lots of providers in St. Louis and Kansas City. So if BJC and St. Luke's want to play hardball, say, no, we need a 30% rise in what you pay us, they're gonna laugh at us. So what motivates these horizontal mergers in different geographic distributions? Maybe Scott's not there anymore. You're muted if you are there.
There you go.
I am. Yeah. So I do want to acknowledge that Kaufman Hall did a lot of work on the BJC St. Luke's deal. So I need to be appropriately kind of cautious in what I share. But I will say I wouldn't underclub the degree to which there are additional cost savings and benefits to the combined system around coming together. That was not the whole reason for the deal, certainly, but there are benefits that come from having a degree of incremental scale. I will also tell you that, you know, the degree to which they can together and invest across the entire state in a much broader geographic area and address some of the things that you're calling out around health equity and the ability to improve access to services and care was really at the core of a lot of the conversations between those two parties. And I think the comments that we've heard today on culture and the really important role that plays in these types of transactions was also really front and center as both of those parties came together. So, you know, there's a lot there. I wouldn't necessarily say in that case it's one factor that brought them together, but it's a range of the kind of dynamics and forces that you've heard folks talk about today. One thing I will say, and this is not pertaining to the BJC St. Luke's transaction, but picks up a little bit on other comments that have been made today. We just put out a report yesterday, I believe, on M&A in 2023. Almost a third of those transactions originated because one of the parties was in immediate financial distress, risk of defaulting on their bonds, risk of running out of enough cash to really operate their business, those sorts of things. And that's double what it was in 2022. So the degree to which, you know, organizations are looking to really stabilize their financial picture and continue playing the important role as a provider of care first and foremost, leading employers in most of the markets that they serve, has really been paramount and something that, you know, we've been hearing a lot about and that I've been directly involved with in the transactions I've supported, certainly over the last couple of years. I hope that's moderately responsive.
No, it's incredibly responsive, and I feel almost chastised, but that was terrific. You know, Steve
This
Sewell.
market,
What?
I mean, the dynamics have changed, right? I mean, you have the emergence of KU. I hope we can speak freely here.
Yeah, sure.
Part of I mean, you see this incredible strengthening of a healthcare organization relative to another. Because when I moved here 29, 30 years ago, everybody talked about St. Luke's. And today, the designation of comprehensive cancer center and then academic affiliation is incredibly strong. And people want KU in their health plan because they want that cancer center. And even though St. Luke's does a very good job treating cancer and many, many other, you know, healthcare related diseases, I think this was, I'm not surprised at all. It's kind of that flight to quality. It's looking for a quality partner. I mean, WashU is a powerhouse. It is a top 20 research institution. That is a powerhouse to bring into the St. Luke's family. And I think it's a
It's a wonderful point, and I want to emphasize that, you know, BJC and St. Luke's coming together is a really classic example of organizations making a decision to work together from a position of strength. They're not in that bucket of a third that I talked about where there's sort of immediate financial distress. So them deciding to sort of get ahead of the market, to work on investing and solving some of the challenges that are present across the state of Missouri and adjacent geographies, I think is a really nice example of what we expect to see more of going forward. For those organizations that are not in distress, they're placing bets on where healthcare is going to go, and the capabilities that they can deploy together are probably a lot better than what they could do on their own.
I'd just like to push back a little bit on the leverage point that you mentioned. This won't give them more leverage. It could, in the sense that they're both serving statewide employees in Missouri, like the University of Missouri system. And under certain conditions, a combination like that could give them more leverage. And the empirical research is very clear that mergers like this, cross-market mergers within the same state, lead to higher prices. The ones from cross states do not, but within the same state, they lead to higher prices. We don't fully
You think
understand
they're
why.
gonna move
but-
to becoming an insurer provider, that they're gonna create their own insurance product to bid to the University of Missouri system?
No, so here's one potential story. Let's say you're United.
Uh-huh.
You're the one who insures University of Missouri employees like myself. And University of Missouri is like, okay, we're gonna go with United. We prefer them. They cover UMKC, they cover UMSL, Mizzou, Rolla, we're covered, okay? Now they lose St. Luke's, let's say, from their network. You might say, well, I still like United. I'm gonna stay with them, even though they don't have St. Luke's. But if they lost BJC as well, it's like, forget that. I'm going with somebody else. So in a story like that, if that's what's going on, then BJC and St. Luke's are substitutes for the University of Missouri, even though they're not substitutes for any particular patient. Nobody in Kansas City is going to go to
That's
BJC.
a really
Nobody in
good
St.
point.
Louis is going to go to Kansas City. But they could be substitutes for employers, even if they're not substitutes for patients. That's the story that I know FTC and DOJ are trying to explore. I'm not sure when they're going to bring a cross-market case, but the empirical research is very clear that these do cause price increases. So you just need a story of why there is a loss of competition there, if there is. And it's not to deny there's any, efficiencies with these, there could be. But the empirical research is clear that these do cause higher prices.
Well, I feel like, we're supposed to facilitate conversation, not drive conversation. I talked so long, I lost Steve Sewell who had a question, so I feel bad about that, and I'd like to not.
And Tony has CAPG up there. That's the collective assessment, public good investment. I don't know if he wants to talk about it.
But other questions, I mean, people.
You have one up there from Steve Sewell.
No, I'll be that. I was gonna go to that next, but I think he's gone.
John, you've worked, and I've worked with you and Tony, there's on this call in the last decade, trying to figure out how we make Kansas City a model for changing the way we think about outcomes in healthcare, right? So we have the whole outcomes. And part of what Digital Health KC is trying to do is to build on something unique in this region. We have a lot of health IT companies, but we want to build on the kinds of work you guys are doing to say, hey, when you come to KC, you want to solve healthcare's biggest challenges. We have partners in the community that are thinking about these same problems. And I'm a believer that we have changed the way, the reason why you're seeing all these digital things happen is because we've digitized this industry. We are the last industry that connected all the X's and O's from the point of presence through the most complicated care. Your data actually will follow you, and you actually have the right to get it. So we have tried to get data from Blue Cross. We tried to get data from United. We tried to get data from HCA. So remember, and I'm not saying these guys didn't eventually come along, but nobody stood up and said, sure, I'll give you their quality data. No, you know how hard that's been. The difference is today as consumers, I can consent to say, you're my agent, go get the data from United, go get it from Blue Cross, go get it from Aetna and Cigna and CMS. We didn't have that before. Now, if you can get a large cohort, a meaningful cohort of consumers that say, I want my data in the quality collaborative. and I want better healthcare. You now have an ability to go get that data and you can manage it through this collaborative. That's what's different. And I think this is where Kansas City could set itself apart, is to say, I'm not saying screw the providers, screw the, excuse my language, mess with the payers. I'm saying flip the model. We've been going on the institutional side. Maybe we flip it down to the patient side and say, nothing about me without me, which you probably, some of you have heard that term. So, hey, why don't we consent in and start telling people we want healthcare to be better, and I'm willing to consent my data into this. And I'm not saying, this is anonymized data as best we can anonymize, which maybe the challenges there. But we got a company in town called Triple Line that is world class in anonymizing data. In fact, Mayo's using it for their sandbox, their digital sandbox around the world, using a KC company. We know we can do this. I mean, I think that's a new locus of control that could emerge if we're going to talk about changing the game and really treating patient-centered, outcome-oriented, quality-focused, and cost-mindful. Okay, I don't really think costs go down. We'll just stop them from going up.
That's a lot of, so, talking about community conversations is the start of things. Then there's what are you gonna do about it? And that's what High IQ is trying to do, right? We're trying to bring together the payers and the providers, and we're trying to figure out how to quantitate the changes in care and outcomes, and also to support those organizations that want to change the way they're delivering healthcare. And that's where the implementation science does. And at this stage, we put our toe in the water. We've started with a couple of early projects. And the reason that we had to delay the, first of all, nobody was attending the December forum anyway, but part of the reason we delayed is how challenging it's been to get the data, how we're thinking about the right model to do it, and what's the right unit of analysis. And, look, we all have to move in this direction together to get a sustainable model. But if we can, we'll be the only place in the country that does this. And it'll be a huge attractant to tech. It'll be a huge attractant to, consultants, those who want to sort of spread what we get going here. It's just, I hope it happens while I'm still on it.
Well, we can do that together. We don't have that much time left.
Exactly. Well, let's work
At
on
least
it.
a couple decades here.
Well, we're hoping a lot of people, look, Optum Health would be an unbelievable partner in this, Tony's been amazing, Blue Cross has been fantastic. We do have amazing examples of St. Luke sharing a lot of technology that they invested in for free with KU to be able to do it, and vice versa. We are slowly building this connection, but as Erica said, it's all about building trust, and it takes a long time. Even though we all agreed as we started, even sharing some data this late in the game is bringing up trust issues, and that's why it's all housed at UMKC, because it doesn't have a hospital. It's all you're part of in-service and educational commitment to the region without any competition, so that hopefully St. Luke's and KU and Shawnee Mission will not, HCA, because their private equity won't participate ever. But the rest of them will all work with us, hopefully, and UMKC will preserve that trust with the respect and the support it gives the different partners. And so that's what we're trying. Other questions? I know we're a little over time, but I was passionate about this topic for a reason. So maybe I should have been the one to do the intro and not the close, but.
Well, it also comes down to what the payers are gonna get out of the relationship, right? So I think it really comes down to understanding what they're gonna get out of it and then maybe building that into it. So understanding that from the get-go and then building that into.
Well, they have to lower the cost of care, right?
Right, but then listening to their needs, there is something that they want. Okay, whatever that is, and then figuring it out how it is that we can actually deliver. But then in turn, they have to deliver.
Yep.
Whether it is, co-creating benefits, whether it is delivering a check to a CBO, getting them to agree to that on paper. And then we deliver whatever it is that we agree that we would deliver to them. Or maybe it's delivering data. It's delivering data to digital health KC, right?
Yeah, they're already, we have Lacey, Lewis Clark Information Exchange, we have Katie, now the Consolidation Network. We've got, which is the Missouri side of St. Luke's and just there, but we're already consolidating that. We've got Great Plains Collaborative that Russ now has got, the city, Russ Wade and, the quarry.
Yeah.
How many more attempts do we need to collect data, right? We've got data. What we need is the consent to use that data for a new purpose, right? And by the way, people are paying for Lacey and Kate, and the quarry is federally funded.
Yep.
Right, which means those projects are supposed to benefit the community at large. And it's housed at MU, KU, and KC, so West Holt's joint appointments there, so I mean, honestly,
The challenge with that, and we don't have to get into, we need to continue these conversations to come up with the solutions, but the challenge is that for us, yes, KU's in it, Truman's in it, but St. Luke's is not, North Kansas City is not, Shawnee Mission is not. I mean, so we gotta figure out, and they all could be, right? I mean, if we could have our dream, then then all of the monitoring of paired outcomes.
well, I mean,
would
this is where,
be easy.
I mean, look, this ain't gonna happen anytime soon, but you were talking about legal framework, in fact, there's not a case law framework for the practice of medicine that's current. But there could be a legislative or regulatory framework that says, you gotta, we already have frameworks to say you gotta share data. That's the information blocking.
Yep.
And all the interoperability and the national data sets for health, and there are a bunch of them out there. The frameworks have been built, the highways have been built. The incentives have not been built, and the stick has not been built. It's been built to say you've got to put a framework in place. We've got all kinds of stuff on meaningful use and its derivatives. But we don't say you've actually got to put stuff on the highway. In a way that other people could use that, that's still coming. So I don't know. I think there could be. So take your state of Missouri example. We tried through Tiger Institute for years to get the state and its universities to think differently about how they should procure healthcare. Right. And I do think they're going to use that leverage of the BJC St. Louis because they've got to be in the state's health plan or your employees are going to have, insurrection. So, I think there's another player there too. I think you could do it. I think you've got state entities here, right? And this is federal money. The federal government pays for 48% of the healthcare in the United States. It's already paying for it. It's just paid for it in 100 different programs. And, so I don't know if there's enabling legislation. I think it's going to be incredibly hard to have that impact us anytime soon. So I think we got to go up with another angle, which may be through consumers or payers, frankly. Payers are powerful, in my view, and getting more powerful in the marketplace.
But we're trying to develop that.
Okay.
So thank you all so much for coming. What a great thing. And for those on the phone, thank you so much for participating. And
Yes.
we'll have to have a 2.0 next year on the same.
And online, please join us for March 14th, when we'll be discussing caring for Kansas City's unhoused. Thank you so much for joining us today.